My name is Katy Gore. I am the Coalition and Education Program Manager, and I'm very excited you guys can all join us for our pre-lunch presentation with Dr. McGee and Dr. Wootton. I'm going to do quick introductions and then pass it over to them. So Dr. McGee is a board member of TIP, who is also a general pediatrician. Dr. McGee completed her undergraduate education at Vanderbilt University and earned her MD at Baylor College of Medicine, where she also completed her residency in pediatrics. She is currently an assistant professor at Baylor College of Medicine and spends her clinical time teaching residents at Harris Health Clinic in an underserved area. She is also a member of the Academic General Pediatrician section at Texas Children's Hospital, where her research focuses on countering vaccine hesitancy and on cancer prevention in adolescent populations. Through work with the Immunization Partnership and the Texas Pediatric Society, Dr. McGee enjoys participating in advocacy initiatives at the state level focused on vaccines and cigarette legislation. Dr. Wootton is a graduate of Washington and Lee University and the Medical College of Georgia. Dr. Wootton completed her pediatric residency at the University of Virginia. She served as an epidemic intelligence officer with the Centers for Disease Control and Prevention for 2 years, after which time she completed her pediatric infectious disease fellowship at Texas Children's Hospital. After her fellowship, she completed a 1-year postdoctoral fellowship in vaccinology at the University of British Columbia Vaccine Evaluation Center in Vancouver, BC. Since joining McGovern Medical School, Dr. Wootton has been involved in all levels of teaching, clinical care, and has received multiple clinical research awards. Her research focused primarily on vaccine preventable infections and vaccine delivery. She currently serves as the Texas Pediatric Society Infectious Disease Committee and the Immunization Partnership Scientific Advisory Committee. So thank you both for joining us today, and I'm going to go ahead and pass it over. If you want to talk about vaccine hesitancy, talking to vaccine people who are hesitant, and childhood vaccines today. So thank you.
All right, so it's a lot of my friends who are up there that I see, so thank you for coming to my section. And you may be hearing stuff you've been hearing me talk about for a while, but we were just gonna, especially with COVID vaccine right now, we wanted to talk to y'all about how do you address the people in your lives who are vaccine hesitant. And I'm gonna start out by just putting up a slide. So Susie and I have actually given this lecture to doctors together before. And I just wanted to show you a chart that I think is really helpful for framing the whole conversation. And this was put out by the World Health Organization. And the fact that the vaccine deniers is red is nothing political. This was put out before anything became politicized. But I think what's useful when you're framing the conversation to think about what level of vaccine hesitancy is the person who you're talking to. Are they just kind of questioning? They've read some stuff, they're not sure. And those are people who you absolutely continue the conversation. You should be able to convince them to get vaccinated. The science is on your side. If they're in that red group though, where they're the vaccine deniers, these will be people who are going to throw at you that Bill Gates put microchips in the COVID vaccine, or, kind of crazy conspiracy theory type of stuff. You are unlikely to change their mind. No one has figured out how to change their mind. Being anti-vaccine or being anti all kind of COVID science has become part of their identity. So by attacking them, attacking their views, what you see as their views, you're really attacking them. It is part of their identity. So anything you say really probably isn't going to go well. And I would say the tactic to take with those people is that you want to keep them from spreading misinformation to others. And we'll talk a little bit about how to address it. But I just like to frame it in this. When you're talking about vaccine hesitancy, you're talking about a spectrum of people. And I'll stop sharing now so you can see our faces.
Yeah, I totally agree with that, with what Lindy had outlined. So at least for me personally, when I'm talking with family members, I don't engage. As you've probably heard the quote, you're not a prophet in your own land. So especially careful with family members. I take sort of a different tact in kind of my professional world when I'm working with patients. I would describe the approach as gentle and taking it one piece at a time. The sort of one theme is not to overwhelm with a bunch of data, and try and understand, and we'll talk about it sort of specifically, what is, kind of drill down, what is the one thing about it they have questions about, and to really not have any expectations around that conversation. Again, trying to keep it open, and it might be over several meetings that we sort of discuss what's happening. But kind of the last thing that I'm doing is throwing a bunch of numbers, because I think it can be risk communication has a lot of facets to it. How we perceive risk is based on a lot of different components, what you've been through before, what you're dealing with now. And so the numbers, and then how numbers come across, can be very challenging. There's a whole field in how to do effective risk communication. So when I say 1% versus 1 out of a million, it's hard for people to wrap their minds around that. So anyways, we'll maybe leave it open and maybe hear from you guys what you would like to talk about within this subject. You can put it in the chat box if that's easier too.
Oh yeah, that's true. And the other thing I would just add is there was, I think, a really good podcast on this. I listened to a podcast called The Dispatch. It's kind of actually center-right, politically billed podcast. And they had an expert on March 26th who was very good on this. So if you're interested in this topic and you want to learn more, I strongly recommend that particular podcast on March 26th, The Dispatch. Getting to where. So I don't see any chat. I was just going to kind of go over some things they talked about, because I talked to someone who had run focused groups specifically on COVID vaccine and what kind of messages were resonating with people when it came to COVID vaccine. And they were specifically looking at the groups that we know are most vaccine hesitant, which for the COVID vaccine, it's different for different vaccines, which groups are hesitant. But for the COVID vaccine, it is tending to be rural, Republican, identify, white males. Is the largest group of vaccine hesitant for the COVID vaccine. And they found that the messages that were resonating with them, one, I think is when Susie's talking about that risk perception, one thing to really realize, and when you're talking to people, and I've said this to people and they're like, oh, the coronavirus isn't going away. We have no indication that it's going away anytime soon. We've only eradicated one respiratory disease via vaccines. That was smallpox, and that took a long time. So we're not thinking that COVID's going away. So when you're thinking about risk, you're thinking about risk of the vaccine versus risk of the disease, not risk of the vaccine versus risk of doing nothing, right? So that's one thing that I have pointed out to people before, just briefly, and they're like, oh, I didn't realize the virus wasn't going away. Okay, I'll get vaccinated. I've encountered a lot of really low level hesitancy where I really did just have to clear up one thing, and they're like, oh, okay. Yeah, that sounds like a good idea. I should get vaccinated. So that's one thing to point out. I think the other really important thing to point out is a lot of people really don't understand how vaccines work well. And they think that since it is something that has an effect for a long time, that it actually stays in your body for a long time. And vaccines don't stay in your body for a long time. And the way that I would describe that, and I learned this from the podcast, this wasn't my idea, but to like a younger person is to say it's a Snapchat message. It sends the message to your body, this is how you fight the virus, and then it goes away. For someone older, I would say it's like a self-destructing message in a James Bond spy movie. It gives the message, then it self-destructs. So just to give that idea that just because the message is in your body, that just because you told your body your message and the body knows how to react for a long time, doesn't mean that the actual chemical ingredients stayed in your body. In fact, they all leave your body very rapidly. And I think that's something that's commonly misunderstood, that is kind of an easy thing for even a non-scientist to just explain to someone.
So we have a couple of questions into the chat. I'll go ahead and read them out, if that's okay with you all.
Mm-hmm.
How do you deal with people, particularly older people, that might argue that immunosuppressed should not get the vaccine?
So that I can take that one. So sometimes it's helpful, I use sort of figures. So we can just start with their decade and look at sort of outcomes that we know within their decade of age, and in particular mortality, and show them how that compares with people who are 20. And I can put that in the chat box in a minute. That's one sort of risk factor, is just your age. Whether or not they're immunosuppressed, so that has different definitions to different people. And so they would be, if they have heart disease, you could hold that, define that as being immunocompromised. Lung disease, they would be, again, back to what Lindy is saying, at higher risk for a poor outcome. And I gave a talk to a group of surgeons in Richmond. And one thing I laid out there for older people versus younger people is the impact then of that serious outcome financially on the family. So one way, COVID-19 vaccine keeps you out of the hospital, keeps you out of an ICU environment. For example, if I got COVID and went in the ICU, all of the family's financial resources would be put into me for my care. And so I don't want to be that person. And I don't want to be that, take our college saving away for our kids. And that seemed to speak to some people, maybe more than others. But yeah, let me put the figure that I used in that talk that was pretty simple about just age and outcome.
So Carter Dugan asked a question. Her twins were asking her this morning, when they get a chance to get the vaccine, if they might have side effects. Is anyone studying who is having side effects with vaccines, and how do you extrapolate that to kids?
Yeah, I think there's a lot of questions about kids and vaccines, so yeah. I'll kind of wrap them all together. As far as the side effects, so right now I have a friend her daughter's in the Moderna trial, and actually the initial stage of the Moderna trial for under 12-year-olds is to give a quarter dose, a half dose, or full dose. So the first stage of that trial is actually a phase 1 type of trial where they're determining best dose. And then they'll look at immune response and side effects for those doses. So it may be that younger kids need a lower dose of the vaccine to have the same immune response. So that is something that they're studying. And I think that also wraps into Catherine Bragan's question. So she's saying that she's seeing a lot of vaccine hesitancy for their kids, where the adults are fine getting it themselves, and they're hesitant about their kids. And they should be hesitant about their kids because we haven't done the trials yet. When they looked at the studies, look at vaccine hesitancy in the fall, a lot of adults were vaccine hesitant. Well, I would have been too in the fall because I hadn't seen the data yet. And then when it came out and the data started to become available about how safe these vaccines are, more and more people were accepting the vaccine, and every subsequent study has shown less and less hesitancy around the vaccine. So I am hopeful, Catherine, that those people who are hesitant for their kids right now will be persuaded once they see the data come out and show that the vaccines are safe, and then more and more people get it. And one thing we do know about vaccine hesitancy, the biggest driver of vaccine acceptance is really what we call social norms. So you feeling like everyone else who's like you is getting the vaccine is what drives people more than logic, more than they think it does. The fact that you feel like your community, people who are like you, are getting vaccinated, makes you get vaccinated too. So I think what the hesitancy that you're seeing now, I'm hopeful will get less and less, like it did with adult vaccines.
Yeah, but to specifically answer, can you extrapolate data from adults to kids? The answer is no. We have an idea, but it could be, they have less. So I think they use the information to gear then how we design the trial. So for example, in adults, if we find, rashes, clearly we'll design the pediatric trial to measure then that outcome. We did see differences in responses to, for example, the Pfizer vaccine reactions based on age. I'll put another link in, and you can see there are differences in whether or not you're 18 to 55 or older than 55 in terms of just local expected reactions to a vaccine. But yeah.
And so, yeah, what they may find is the kids have more side effects with a higher dose and they decide to go with a lower dose for them. And that is definitely something that could happen. And I think that's why you're looking at a while before those under 12s are going to have the vaccines approved by the FDA. Most experts I'm listening to are saying really December, January for the under 12s. I do think that there was a question about 12 and up. Pfizer submitted its information to the FDA. The FDA, as far as I know, hasn't set a meeting date to say when that's going to be. I'm not sure what's going on. All my doctors groups are exploding with what's going on. Why aren't they doing it? And I almost want, I can't speculate. I don't know if they're trying to make sure all the adults have a chance before they have this onslaught of kids wanting it or teenagers wanting it, or that they're really tied up with J&J vaccine right now. I'm not sure what's going on.
Yeah, that meeting is tomorrow about
Yeah.
J&J. So maybe that's it.
But Pfizer submitted it. Moderna's wrapping up its data right now on that age group, the 12 to 18-year-olds or 12 to 16-year-olds. So I'm very hopeful that before school starts in the fall. I don't know when people are asking about kids in camp. I'm not sure about at what point this summer it'll be available.
Yeah. So
So
Diane had a question. Do you think that all focus on COVID vaccines will help the overall vaccine conversation long term? So I think what this is about, the fact that we're diving more into maybe vaccine hesitancy in the context of COVID-19 more than we were in the past, I do think is helping us understand this could be sort of a silver lining and how to message and communicate around vaccines. As an example, there's a lot of funding coming down from the government for projects that go into communities, such as Lindy identified as refusing COVID-19, to understand how should we tailor these messages better to speak to you. A lot of the CDC education or information that we give out is geared towards people who've already decided to get the vaccine. And so I think it will improve how we communicate overall in terms of designing specifically tailored messages for these different groups.
Yeah, I think I'm a little bit more pessimistic. I'm really disappointed with how politicized vaccines have become. And it didn't used to be considered a political issue. We've always worked with both political parties on vaccines. So I'm very disappointed by that. And I do think, like I said, if something becomes part of your identity, it is much harder to change people's minds. And what we're finding is that political parties are becoming part of people's identities. And if one political party decides that, they're vaccine skeptic as part of their identity, that could be a problem for us. Right now we continue to have supporters on both sides of the aisle. But, like I said, polling is showing that people who identify as Republican are more likely to be hesitant. Still, the vast majority of Republicans are getting the vaccine. So that's the good news. And so what I would say, if you have friends and family, we all have friends and family who are Republicans, hopefully, you should get them to publicize the fact that they got the vaccine. Put it on social media. I got the vaccine, yay, da, da, da. It's that social norm thing. And then when talking to people, say, most Republicans are getting the vaccine. That's very true. The headlines are Republicans are refusing, but really most are getting it. And so that whole idea of social norm, and that's the way to influence people.
Definitely. And maybe we sort of answered Catherine Bragan's question. A lot of people seem more hesitant to have their kids get the COVID vaccine when it is available and worry less about themselves getting it as an adult because of the unknown long-term side effects. Can you shed any light on this concern? I think this sort of speaks to sort of the risk communication or risk perception. So you can imagine Lindy and me have a quite different risk perception, having taken care of kids with COVID in the hospital, in the ICU, taking care of family members, versus someone who doesn't have that direct contact. So I think, the way to handle this, again, is to sort of understand specifically what is the concern and maybe dive in, well, what is your understanding about, COVID disease and what it can do? But those are tricky. I don't know, Lindy, do you have something to add about that?
No, I just think, I think that as the data comes out on kids and it shows good efficacy and we have longer results on adults on the vaccines, that people become less vaccine hesitant as far as kids go.
And to mirror that, also more long-term data on the impact of COVID infection.
Yeah.
You can imagine it's very easy when we're doing clinical work or research to capture hospital outcomes, who died, who got intubated, who got discharged. It's very challenging and costly to set up trials that follow cohorts long period of time. So to get 6-month outcome data on someone with COVID or 12-month, those are longer studies and cost more money, but we are starting to see things like impact on fatigue, impact on being able to return to their normal activities of life. The longest that I've seen published so far is just 6 months out. But I think to speak to also, okay, yeah, you may not get intubated, you may not get in the hospital, but you have 8 months of fatigue that's preventing you from going to work is a huge impact on your quality of life. And in many respects for people, may be more terrible than death. Some people would prefer, all right, I just want to get out of here, than having fatigue for 12, who knows how long. So, that's where we use stakeholders, our community, to help us guide then the research. What are the outcomes that are important to you? Walking, being able to ride my bike, things like that. So to mirror, again, what Lindy was saying, as we learn more about the vaccines, more safety data, and then to mirror that, then the impact of the infection. Not just adults, but kids.
It's always looking at the risk of the virus versus the risk of the vaccine. It's not looking at risk of vaccine versus doing nothing. And our brains like to do that to us. We're all of us are inherently more scared of doing something than doing nothing. So getting that shot is doing something. It seems easier. It seems less risky to do nothing to our brains. So we have to tell our brains, no, getting this virus is risky.
Can you think
A
about
question from Ed?
Yeah, interventions that we do in medicine. When you come into the hospital, I'll do 15 different interventions that all have risk associated with them with minimal amount of data. You look at the data that we have in terms of time to intubation, how I set your oxygen, probably 0 or little, compared to the data and information that we have about vaccines is exponentially different. But for some reason, people don't care if I just give them amoxicillin for respiratory illness, which can adjust your flora for 6 months, but they're going to zoom in on a vaccine, which, because we're giving it in the context of someone being well, has to adhere to higher levels of evidence for safety than all the other million things we're doing in the hospital that have no data. So I think that also it's irrational. Anyway, yeah.
Ed, did you have something?
Yes, there we go.
I am not that computer savvy to type in a question, if I may. I've been retired as a pediatrician for about 17 years, but I remember that we really never had any problems with people wanting immunizations other than the pain involved and everything until the measles vaccine. Am I historically correct? It seems that that's the one with causing ADD and everything else that really started this whole process. And do you see that as a spillover with the COVID, that people are worried about so much in the future that maybe they're not expressing? They're talking about the present, but it's the future they're worried about. Has any data come out on that?
Definitely, we saw a change in the anti-vaccine sentiment with the publication of Andrew Wakefield's article in 1998, which was later found to contain fraudulent data. So that was kind of the beginning of the anti-vaccine movement, the strong anti-vaccine movement. There's always, ever since there's been vaccines, there's been people who oppose it, because anytime government tells you to do something, there's always going to be people who oppose it, right? But that's when it really got strong, and that was centered around the MMR vaccine. I think that there's the general vaccine hesitancy, and then there's flu vaccine hesitancy, then there's HPV vaccine hesitancy, and then there's COVID vaccine hesitancy. And I would put those into 4 different categories of people. And some people are vaccine hesitant against them all, but some people are very particular to those specific ones. So that's where, like, as a pediatrician, I just have to feel them out to see which group they are, and I'll tailor my message accordingly. But the people who are in that red group, a lot of times are going to be very vaccine hesitant. And that's when I said I'm pessimistic. That is what I'm worried about, is that COVID vaccine hesitancy will spill into all vaccine hesitancy for a group of people. I'm very concerned about that.
And the other concern, to pick up on that theme, is the degree of vaccine hesitancy we've seen among healthcare workers. I think that was quite surprising, in particular among nursing home staff. And there's just a recent article about an outbreak in a nursing home that the index case was a healthcare unvaccinated worker that led to, I think it was 3 deaths. So we are trying to figure out also within that context how to approach that.
Yeah, and I don't like the headlines about healthcare workers, because I think people read the headlines and they don't realize what kind of healthcare workers they're talking about. So you should know, at Baylor College of Medicine Department of Pediatrics, 94% of doctors are vaccinated already. My guess is that 5% of those just haven't turned in their paperwork yet. And then a certain percentage of those are probably pregnant in early stages of pregnancy, which is reasonable to wait on vaccination at that point. You know, so when you're talking healthcare, so I fear that when people see healthcare workers aren't vaccinated, they're thinking people with a lot of training in immunology and pharmacology are deciding not to get vaccinated. They're talking about people who are nurses' aides at nursing homes as healthcare workers. And so, although they're seeing the results of COVID, they may not have the scientific background to evaluate all these things the same way. So I do think the headlines can be very misleading.
Yeah. Tammy, did we answer that question she has, Lindy? So do you have a guess as to when 12 to 15-year-old children can be vaccinated?
Yeah, I think we don't know. It's, like I said, it's the Pfizer submitted it. They submitted it like 2 weeks ago. Normally it only takes 3 weeks for the other vaccines. They submitted it as a supplement or amendment to the existing. So it is a little bit of a different process. That's what all the doctors are asking too. If you could see my doctor's Facebook groups.
Other resources I use are non-CDC with people who are hesitant. So I'll send them to Children's Hospital with Paul Offit's Vaccine Center, or Texas Children's. So not sort of government affiliated resources for information. I'll put those in the link. They tend to be suspicious.
How do y'all address people who cite J&J in the recent issues that have come up and say, this is exactly why I didn't get a vaccine? What's a good response to that?
I mean, to me, it's exactly proof that our system works to detect, you know, any extremely rare side effects. So I would say, you know, if you don't want to get the J&J vaccine, don't get the J&J vaccine. I don't care. Go get Pfizer, Moderna. If you're really scared of the mRNA, hopefully Novavax will be out soon. Novavax is a very traditional, old school vaccine. It's just the protein plus what we call an adjuvant to wake up your immune system. So there's going to be other options. So if they have particular J&J issues, then don't get that one. I don't care. But it shows that our safety system works. And if we were able to detect between 8 and, you know, probably end up being a little bit more per 6 million doses. And we haven't detected that yet for Pfizer, Moderna. And Pfizer, Moderna, we've been given so many more doses than the J&J. I mean, those vaccines are safe. Because, you know, we're picking up stuff that's 1 in a million.
Yeah, again, it's below what would happen just as walking to HEB. So it has to do with rates. And again, that risk communication, we write our clinical trial consent forms at a 7th grade level, which is what the general population. So again, this speaks to general understanding of mathematics, how these rates are different. So it's a challenge. Sometimes we'll use pictures, we'll have, a person that's red out of 100, white, to say that's the risk, and that might help. But it may be these numbers are just hard to people to wrap their head around. I'm trying to find a figure to show how the risk related to J&J is different from just living risk of clots. Yeah.
But yeah, to me, when I saw that they had halted it, I was like, honestly, my reaction was I can't believe they could pick up so quickly something that is so rare. That is amazing. That is science working. And that was my honest response to that. So you can tell them. I was on a call with a doctor who said she thought that was amazing news. I mean, that's amazing that we were able to pick that up.